Okay, welcome in everybody. My name is Lisa Novak, and I am a Catch board member who's going to be moderating today's Lunch and Learn. I also happen to be a neuropsychologist, and I am particularly excited for today's topic as it was born in large part out of the questions that I get most frequently at work each day. And now I'm honored to introduce you to today's speakers, Dr. Natalia Kaczmarek and Laura Tatgenhorst. Natalia is a licensed clinical psychologist and the founder of Indigo Therapy Group, a thriving private practice located right here in Northbrook. And Laura Tatgenhorst is a licensed social worker and a member of the Indigo team. Both presenters self-identify as neurodivergent and bring a host of personal and professional experience to their work with children, teens, and families. And so without further ado, I'm going to turn it right over to Natalia and Laura. Thanks for joining us, guys.
Thank you
for
for that
having us.
beautiful introduction. I am going to go ahead and share my screen so that we can get right into it. Let me start with this. I have ADHD. It might come out during this presentation, and that's mostly coming from a place of passion. I can talk on and on and on about this, but I've received a lot of guidance here from Lisa and from Laura to try to narrow this down and be also broad. So I'm really anticipating your help today and try in the Q&A portion to really address maybe some more of the specifics. But if you feel like some of the presentation didn't dive in, that makes sense. That's how it was organized because we really wanted to address your concerns today. So Lisa, you said it all. I have nothing else to add. But Laura, go ahead if you have anything to add to your introduction.
Gosh, yeah, she did a very good job. These are just more random things about me. I also have ADHD and autism, and we talk a little later about the co-occurrence of that. And, it's an interesting experience. I hope that more providers speak up about having these, at times struggles, but oftentimes I feel like it brings us closer to who we work with.
So I was thinking a lot on how to introduce today, and two words kind of kept popping up for me. The words were awareness and acceptance. I think for a long time, across all kinds of neurodivergence and mental health, there's been a huge push to people aware, make them informed, allow knowledge to be put out there so that people could better identify and maybe normalize what was going on. But I really want to challenge people to also focus on how we can incorporate acceptance as it relates to ADHD and other things. Because the truth of the matter is, anybody who has probably been super successful and creative and innovative may have had some ADHD. It is a wonderful gift. However, I think during development, it for sure has its struggles. And that's why I think we're here today. I will say, as I say to lots of parents, development is on your side. Even though some of these kids with ADHD, myself included, and Laura too, had maybe some loop-de-loops throughout development, there is a wonderful thing that starts to happen as kids grow. And that's one of the greatest things with starting intervention earlier, is that you actually start to see the impact of that a little bit later on. So although it's frustrating, you can definitely see how much of a difference it makes in kids' lives. So we're going to have a couple of different sort of topics in the presentation. We're going to talk a little bit about the common myths we sometimes see. We're going to talk a little bit about ADHD in females. Of course, we're going to mention our boys too, but sometimes it looks a little bit different for girls. We're definitely going to be mentioning social and behavioral health, a lot of the things that sort of happen simultaneously with ADHD. We're going to briefly then discuss the co-occurrence of ADHD and autism, and then what to do with all this.
Oftentimes, I see a lot of parents or maybe educators make these sorts of assumptions about people with ADHD, whether they know they have it or not. And this comes out a lot in childhood when they have a lot less self-regulation. So you might hear people say things like they're not being parented right, or they're not trying hard enough. But we need to remember that people with ADHD, their brains are being rewired, and it's not something that's necessarily within their control or like an active choice that they're making. And, some of these assumptions are very harmful because, in fact, people with ADHD sometimes have to try twice as hard as those without it. So it's not something to be ashamed or embarrassed about, and it's something that is very treatable and workable with a lot of practice. So there are 3 types of ADHD, and for those that don't know, ADHD stands for Attention Deficit Hyperactivity Disorder. Even though hyperactivity is technically in the name, it doesn't mean that everyone with ADHD is necessarily hyperactive. The first subset is inattentive ADHDers, and these are people who are often a little bit tougher to spot because these people are very intrinsic and within their own heads. So these are the daydreamers, the folks who might be a little more zoned out in school, have trouble listening to detail, and they're in their own heads a lot. So because of this, it can be a lot harder for folks to spot this. And in fact, with a lot of my female identifying clients who have an attentive ADHD, they often don't get diagnosed until adulthood when it comes out in maybe a working environment. So hyperactive presenting folks often, on the other hand, are spotted a lot earlier because they're more external and express themselves in ways that sometimes people find disruptive, like through fidgeting, maybe raising their voice, talking excessively, or not being able to sit still. And this can lead to people having trouble with sustained tasks or sitting still for too long. And sometimes it also shows up in having trouble regulating their emotions. And the combined type, which is both of these, show elements of both. And it can be a little confusing because there are some people who find inattentive and hyperactive to be 2 ends of the spectrum, but there is really a lot of overlap.
I have this example coming to my mind. Context matters. I think a lot of times, especially for kids or people that tend to have maybe a more mild presentation for whatever reason, they show a lot of inconsistency between contexts. And that's really confusing. It's confusing for adults because there's this idea of like, well, they can keep it together at school, but not at home. And man, can that be a nightmare for a diagnostician when one of the criteria is you got to see it across settings. Oftentimes, these folks are often missed. I think of myself because when I'm in session with my clients, you better believe I'm zoned in and listening to your experience. That's part of my job. I mean, if I wasn't doing that, I'd be a pretty bad therapist. But when I go home, I kid you not, my partner has to say things to me 3 times. And we get in a fight. I often say, why are you repeating everything? And undoubtedly, it's because I keep missing things. I see this a lot with kids with school where they're responding really well to structure. Maybe they're responding to social pressure, and then they come home and they completely unravel. So that's something to keep in mind too, of context and how that might really impact some of these symptoms, for lack of a better word. A lot of times when kids come in and they haven't received a diagnosis of ADHD, parents might explain other reasons of why they're seeking support. And so these are some categories in which we see with all kids, diagnosed or not, with ADHD that are topics of conversation and clinical work. So I think first and foremost, I want to discuss rejection sensitivity dysphoria. What does that mean? The kids got a shame corner, adults too, because of the kind of consistent negative feedback loop, because they're not on task or they're doing something impulsive or you want them to do something at a different pace or whatever. There's a lot of negative feedback loops, even when adults try their best to monitor their delivery. Kids sometimes, and adults, develop this sensitivity to rejection and in fact will anticipate it. They sort of create this idea that others are critical or maybe others are rejecting. And you can, just kind of imagine all the scenarios in which that may cause complexity, whether it's with friendships or dating or later in the workforce. there's nothing but feedback loops. And if you're sort of expecting rejection, it makes people really ashamed. I also see a lot of things related to time blindness, kind of losing track of time, of not pacing themselves in accordance to others' expectations. Sometimes there's this hyper focus in something they're doing, or maybe even a little bit of avoidance where there isn't this just sort of natural awareness, perhaps. And again, that might snowball into a lot of things not getting done and causing other types of problems. So sensation and thrill seeking. So anybody with any neurodivergence tends to sometimes have a little bit more sensitivity to all the senses. And we actually have a lot more than just the 5. There's actually 7 basic senses. So there's the 5 you can think of, and then there's the vestibular system, which has to do with input relating to your body sort of in motion. And then there's proprioception, which is all of your muscles and joints kind of giving you a sense of your body in space. I mentioned the 7 because those are the easiest ones that we can intervene with, especially when it comes to regulation. But going back to the sensation and thrill seeking, when you pair a little bit of that sort of maybe sensory exploration with impulsivity and that good feeling boost that these kids tend to get more of when they do something new or exciting, there's just a lot more pull for them to get distracted by those things or get into sort of maybe dangerous situations just because of that pull to really engage in those activities.
Does anyone know what interoception is? I can explain it as kind of like an awareness of your own body, like knowing you have the sensation that you're hungry, or perhaps needing to go to the bathroom or drink water. And sometimes, kind of like what Natalia just mentioned, folks with ADHD can tend to ignore these sensations when they're fixated on something that might be more of interest to them. So it can lead to problems like passing out or, getting shaky if they haven't eaten or drank water all day. And pathological demand avoidance, I feel like sometimes goes hand in hand with rejection sensitivity because they might be wanting to avoid whatever it is they're avoiding because they're afraid of the outcome resulting in rejection or punishment. But I would explain pathological demand avoidance as when a person with ADHD is asked to do something and they kind of avoid it just because they are specifically asked to do it. So an example might be, clean your room. They would be less likely to do it specifically because it was asked of them.
And Laura, remind me, did we talk about interoception as also being connected to bedwetting?
Yes. So that's a very common thing in younger children because, they might not know they have to go to the bathroom, so they ignore it and wait as long as they can until they actually wet themselves.
Talk about if you can't identify your bodily functions, how complicated is it to then identify your feelings, which are so much more ambiguous, abstract, and, quick moving, I guess would be the word I would maybe describe it. Boys are more frequently identified faster and at greater numbers because they tend to present with things that are more obvious, more of the behavioral concerns, more of the impulsivity. That's something that we should definitely keep in mind because for girls, a lot of times it's underdiagnosed or misdiagnosed. So something to think about is that there's sort of this interplay of genetics and also societal norms. So the way society frames what's normal and what the values are very much impact how things are expressed and how they are perceived by others. And girls tend to, more often, not everywhere, not all the time, but grow up with a little bit more pressure to be more behaved and organized. And so you see a lot more masking and you see a lot more compensation. And what they present with is more of those inattentive symptoms that Laura was talking about earlier. I think also genetically, the double X chromosome is very protective. And so across the board, you tend to see sort of a smaller or blunted expression of things, which is actually pretty cool. I think another reason, again, going back to sort of the societal stigma and norms discussion, is that more often than not, when a girl comes to maybe a therapist or a clinical setting or whatever, things like depression or an eating disorder will actually sort of present as like the more immediate issue. But a lot of times when you treat that, right, or support that, what you'll see is sort of this revealing of the ADHD. You'll kind of see that shine through when some of that mood and mental health stuff is taken care of. And so that's another reason why ADHD is sometimes missed in girls. Fun fact, girls with ADHD tend to have migraines 3 times more, and boys tend to more often be diagnosed with sleep apnea. So there's just a lot more that we're starting to kind of understand better about ADHD and all neurodivergence. We have our categories, but it really doesn't actually capture the complexity of how it affects the whole system. We're just, kind of learning those things now.
And I wanted to kind of talk a little bit about comorbidity. So there's higher comorbidity, meaning multiple disorders or experiences of folks who have ADHD, and these things can evolve throughout their lifetime. So what might present as distractibility in childhood can lead to maybe being distracted while doing things like driving. So that can lead to car accidents, inconsistent self-care, and impulse can kind of lead to things like accidents occurring. People can take more ER trips, or the impulsivity can lead to like misdemeanors, getting arrested, and unfortunately sometimes death, which is terrifying to think about. ODD is oppositional defiant disorder, so like kind of resistance to authority figures. That in children can show up, and then because ADHD a lot of the time has to do with sensation seeking, thrill seeking behavior, sometimes means that it can evolve into substance disorders in adulthood because they want to feel that feeling of thrill seeking.
Laura, can I jump in for a quick second?
Of course.
Okay, I recognize that all of that stuff is so anxiety provoking, and a lot of parents often go to worst case scenario. I want to interject and say, take a breath, because this is exactly that loop-de-loop kind of developmental thing Laura and I were talking about. ADHD kids are sensitive kids, and they learn by doing. So they not only are they picking up more, and that's going to make them a little bit more prone to some more moody stuff, they also sometimes learn through natural consequences. And our society is very punishing. And so something that I want everyone to think about is that there is definitely some normalcy to testing boundaries in this loop-de-loop, and that it doesn't have to be the forever at all. And in fact, there can be so much good from learning emotional intelligence stuff early on that actually makes them more successful adults than even neurotypical adults. So sorry, Laura, for interjecting. I just kind of wanted to point out that it is hard to think about this stuff, but this is, just something we all have to kind of be real about and then also figure it out.
Yeah, and by no means does it mean that every person with ADHD will eventually develop into having like a drug problem or get misdemeanors. So that's a more extreme representation of that.
This is just a list of different things that ADHD tends to present alongside with. They sort of occur at different rates. It doesn't really matter, but just wanted to put on your radar that it could be quite a bit of different things related to mood, all the way to other types of neurodivergence like learning disorders or tic disorders or autism. And these things sometimes, because kids are like cats and they really show like 5 symptoms, and they're not always great verbalizers, sometimes there's a lot of stress around what is this, and it really takes time to really sort of get more clarity, because a lot of the symptoms for these labels, they're based on adults. And so I think that can sometimes be another stressor, is that you're seeing this dysregulation and you want to know what it is. But I sometimes just kind of lump it in, it's all one package. And it doesn't really help to necessarily know what it is earlier on, when you just got to focus on intervention and what helps.
I wanted to talk about how autism and ADHD can share a lot of similarities in that they're both disorders that involve sensation seeking and a lot of hypersensitivity. So most commonly, like the stereotype is that we see a lot of autistic folks prefer sameness and routine, whereas a lot of ADHDers like spontaneity and unpredictability. So a lot of factors in our environment can sometimes trigger these sensitivities. So someone perhaps with autism might be very sensitive to something like overhead lighting. And I, in my office, have indirect lighting to try to, avoid overstimulation. And for folks with ADHD, they tend to have a higher threshold for environmental factors, which makes sense because sometimes they will thrive in high energy kind of environments like concerts or theme parks. Having both is definitely a very confusing thing because it's not a 50-50 split. It's not like half of the time you're sensitive to high energy situations and then half the time you're not. I have both ADHD and autism, and sometimes it feels like having two wolves inside of your head fighting. Over time, you get to know what types of particular strengths you have, as well as limitations you have, and you can absolutely navigate those and figure out what types of environments you best are suited in. So it's possible to work through it and thrive really well.
So what can you do? Oh my goodness, this was almost the hardest slide because it is so dependent on each individual kid and family. I think number one, reaching out to a therapist to help you figure out where to start is wonderful. Not every therapist is the same, and there's a different therapist and different sort of modality or treatment method depending on what your kid needs. Some kids need more behavioral, some kids need more play, some kids need more maybe social skills. It really, really depends. I think alongside of that is just consulting with a prescribing physician. I understand that there is always a stigma around medicine. I myself had that for a very long time. I do now take medicine myself to manage ADHD, and it has been life-changing, but I still find myself saying, hey, you know what? There's some days where I need to push through. That's my personal journey. I think for parents, you don't want to wait until it's a crisis. So if you notice that your kid is sort of teetering, okay, they're good at school, but sometimes at home they're a wreck and it's not every day. Again, those are the hardest kids sometimes I see. Just get your ducks in a row, get the people you like. These psychiatrists and prescribing physicians have lists for 6 months, and just talk to them. You don't have to sign up. But then if you do need that, you have it. I think also supplemental therapies, again, it depends on what your kid needs, but occupational therapy to help organize their sensory system and teach regulation strategies is wonderful. Speech therapy, obviously for social skills, or feeding therapy, if you're noticing a lot of AFRID, or that's the label we use for like limited food intake, or being a very picky eater. Certainly not all picky eaters have AFRID, but some do, and so seeking out feeding therapy for that. Pelvic therapy, perhaps for kids who have some bedwetting. I think beyond that, if you really want to get some very objective data and you really want to start teasing out, okay, what are the specifics to my kid, seeking out a neuro or psychological evaluation. That is so integral to really understanding your kid, because the adults, even with an astute clinician, is going to be, using a lot of clinical judgment and hypothesis. But with that report, you get a lot of objective data, and that might help guide other recommendations. For example, school accommodations. Schools really, really value those reports. And again, if it's another one of those things where it's better not to act in a crisis. So if you're starting to suspect some things, wait lists are long, try to get on the testing wait list and you can get the ball going. You can even show the school the report if you feel comfortable, just to even see whether accommodations would be helpful. You don't have to sign up for anything, but it's all about, sort of, what's the word? Like just organizing and case management. And those are like therapist words, but I can't think of another word to better describe it. And then of course at home, with the feedback from the therapist or OT or physician, really learning to implement structure that works for your kid or sensory components for regulation. I think that's really huge. That's embedded so much at school, and sometimes we don't realize how much they have that, and then the stark difference that might occur when they're at home. And so really just making sure that you find the ones that work for your kid. And that's a trial and error. Not every type of routine, or certainly not sensory intervention, is relevant for every kid. It is definitely trial and error. And lastly, just getting informed. We are hoping to put together a list of resources for everybody today, sort of based off the questions that we hear, but you can certainly start on your own, and seeking out consultation from any of these providers would be another way of getting informed. So that's it for our presentation. Lisa, I hand it over to you. I think this is the part for the Q&A. Is that right?
Yes, it sure is. And before we dive into some of the questions that we've already gotten, I wanted to start with a pretty basic one, which is for parents and other folks listening here who have a child who maybe hasn't been diagnosed with ADHD, but they're seeing some of those symptoms, or they're just finding their kid sometimes does have trouble sitting still, or sometimes seems like they get lost in their own head and has trouble focusing. Can you talk a little bit about how you advise families as to whether they should be concerned, whether there is something, worth further exploring there, or whether it's just part of typical development?
Oof, that's a great question. I think, I was just having this conversation with my partner yesterday, and I'm not going to bore everybody with the philosophy of it, but I think from a clinical standpoint, something that we are always looking at is how much does it impact your kids' functioning? In other words, is it getting in the way of them doing school, making friends, finding peace in their hearts? And to what degree? Now, some kids have a really high tolerance, so they may be able to cope and deal with a great amount of difficulty, whereas others may not. And that's where I think it can be a little bit frustrating, because if you happen to have a child that has a really low tolerance, it sometimes feels a little bit more frustrating because there's maybe this belief that they got to follow or catch up to speed to some expectation. I think at the same time, it's fair if there's concern around pathologizing something. And that is really, I think, a family specific choice and value. There are times where maybe there is concern that labeling something will make it abnormal, and that's a fair discussion. More often than not, especially for girls, it's very helpful to have a label, because we actually see in the research that it mitigates a lot of self-esteem issues, because there isn't this blaming of the self that happens. Oh, I'm stupid, I can't get anything right. So that's really dependent family to family. And overall, if you feel like your kid is struggling or not reaching their best potential, that would be a great time to start reaching out. Does that answer the question?
It absolutely does. And I'm just going to throw a part 2 in with that question, specifically around anxiety. And do you find that ADHD sometimes gets labeled as anxiety, or vice versa, that sometimes there really is just anxiety, but it starts to look a lot like ADHD? And how do you work through that with families?
Oh, yeah. I mean, typically when people see restlessness, anxiety comes to mind, or fidgeting. So they co-occur pretty commonly. And I would say it can be tough to discern sometimes, like separate what symptoms are under what diagnoses, but I would say, a lot of them do overlap. And I always say, treat the patient, not the disorder, like individualize what they need and don't always follow the books for what, people with anxiety or people with ADHD need. Sometimes you have to really think outside of the box and just pay attention to what the particular child or adult may need. So, yeah, it can be difficult to separate what is causing what, but just focusing on helping the person alleviate the symptoms is kind of where I go off of it first, at least.
And Laura, can I piggyback off of that? I like what you were talking about with individualizing it. When I see a lot of kids, there's sort of two categories. I assume there's anxiety. I mean, we all have anxiety sometimes, but especially with our ADHD folks, to your point, Laura, it is super common. And so there's two things that I look at is number one, understanding their sensory needs. If we know that they're more sensitive and they're taking in more information, that is just overwhelming to your nervous system. So really finding strategies to calm the nervous system and help them may alleviate some agitation that looks a lot like typical anxiety. But also, if there is negative feedback loops happening, whether it's an adult redirecting a kid, or maybe a kid has already internalized this idea that I'm different and I'm bad. So they might be silent to you, but in their minds are thinking, oh my gosh, I'm going to mess this up. That's where we see sort of that thinking component of anxiety, where reassurance, encouragement, providing second opportunities, those things become really helpful. Messaging like having the courage to be imperfect or practice makes improvement. Really accounting for the fact that it's a development and a journey and you don't have to be great and perfect all the time. That's where that work comes in. So there's sort of anxiety in these two realms that I look at, and that looks really different for every kid.
Yeah, makes a lot of sense. And yes, it is a very difficult one to decipher. I will say it's the one that we grapple with the most day to day at our office, really figuring out the underlying. And it goes back, I think, in part to some of the discussion around differences in presentation between males and females. I find oftentimes providers are more readily, or just they're more ready to diagnose ADHD in boys, and in girls they'll diagnose the anxiety first, and sometimes it's much later that the ADHD ends up coming out as part of that, because the anxiety then it kind of diagnostically overshadows the ADHD. All right, we've got tons of questions coming in here. One that came in before we actually started today that I just want to mention was a question about different resources, books, podcasts that are available for parents. And I know we don't have one today, but our speakers here have agreed to create a list that we can send out to everyone that participated. So I just wanted to make sure that we noted that. One question that we got is about school accommodations that are helpful for ADHD, and how to, is there a resource or a place that you can go to find out what accommodations could be helpful for a child?
Well, Lisa, I feel like that's your territory, to be honest. I will say this, there has not been one 504 plan or IEP, which are different kind of routes within school special ed, that look the same for each kid. Certainly, there are accommodations that are more common, like extended time, fidgets in the classroom, being allowed to take breaks, shortening the work. But it really comes down to what your kids need. Like I have some kids that process really quickly, and the extended time is almost like a joke for them because they're actually finished in half the time and they've done it really well because they're great test takers. There are other kids that need to spread it out over 3 days. And so really, I think that's where the neuropsych is critical. And although the school can do testing, I highly recommend going privately because the school is going to take too long and they're not going to be able to provide you as much information. They're not allowed to diagnose and they're not as comprehensive. So seek a private evaluation for school purposes. much better quality, more worth your while, and you're not putting the kid through as much stress with all of that process.
All right. Another one here is, other than doing therapy, like psychotherapy with a social worker or a psychologist, and or doing OT, are there any other therapies or interventions that parents should look into for different presentations of ADHD?
I could have a bias towards this. I really enjoy including parents into the therapy sessions. So for sure, having your parent consultation with the therapist for your parenting tips. But sometimes I've noticed that including parents into the therapy with me is really helpful because we get to sort of explore together what maybe co-regulation tactics work. And I sort of get to model how to deal with dysregulation or how to respond to things that sometimes may seem overwhelming or unreasonable or like off subject. It's just a lot easier for parents to see that sometimes. Now that's my bias. There are a few theories. So there's like PCIT, parent-child interaction therapy. There's TheraPlay. There's a few different theories that will just naturally include parents, but that doesn't mean that your therapist is wrong if they're not including you, but maybe explore asking about that. I've also seen a lot of success just with like family therapy. Now, if it's a younger child, things like using play therapy and adventure therapy are critical, but it's a way to almost reestablish connectedness. Because sometimes I notice that, especially if it's a family with multiple kids, there almost can be like a stigma happening within the family where one person, that usually the client I'm seeing with the ADHD, feels different and is maybe treated differently. And so really reestablishing the health of the family system might be really important. Even if it's not treating ADHD specifically, remember the family unit is the first model of society for kids. So based on how they're navigating your family will then theoretically translate to outside environments. And so even though it might not make sense, like, okay, how is this helping the ADHD? It's sort of one of those things that the feedback loop comes later in life.
Makes
That
sense.
makes sense.
Yeah, there are a few great questions here about specific, tips that we can ask a therapist here of how do we handle these types of situations. So one of them is massive tantrums and meltdowns. Any suggestions or tools to help when that happens?
I would say trying to redirect as much as possible. Like, hey, something else is going on around us. Why don't you look at that? Or saying, it's okay. I'm, seeing if you can find what the tantrum is stemming from. Like maybe someone's overwhelmed. Maybe someone was upset they didn't get their way. Whatever it may be, just communication is so important. And modeling that for kids at a young age is so essential to good communication skills growing up. So I would say, and I'm sure that this parent probably does ask, what's wrong? Just trying to be as attentive as you can be while, dealing with something that can be very distressing as a parent to see. So I don't work as much with younger kids, so Natalia might have more concrete ideas.
Well, Laura, I think that you actually hit on like exactly what I would have said, which is first and foremost, gathering data, trying to find the pattern. If you can predict it, you are already more prepared. I think number two, you already mentioned it, Laura, is maintaining a calm demeanor. If you're yelling, it's escalating the situation and certainly not going to promote calmness. And you're not doing your best. And then you may have your own anxiety that's coming up about that, right? And it's hard to meet your kids' needs when your needs are also not getting met. And so working with your own therapist to sort of prepare and build up your resilience, because unfortunately, sometimes a lot of dysregulation is par for the course. I mean, that your kiddo is trying to organize their nervous system. They're maybe misinterpreting the environment. They want to do well and feel like they can't. They're frustrated and like discombobulated. There's like a million reasons why like they're off kilter. And so you're sort of their external executive functioning unit. And so if they're getting really dysregulated, the more structure you can provide, the better. I mean, think about it. When we're really, really anxious and flustered ourselves, the first thing we do is settle in at the desk, create a to-do list, step by step, think about what to do, right? And cross that off. And you really sort of try to get in the zone. You need to do that for the kids too. And they may not always respond. That doesn't mean they're rejecting you. It just means that their learning curve is a little bit different. So even if you're asking them, hey, what's going on? Or when you're calm, we can talk, or help me understand your concern. Even if they're not responding, again, feedback loop might come later. You're structuring to them the expectation and what's maybe like typical and expected. There's a lot of other recommendations related to co-regulation that I would refer you to your therapist to ask about.
Thank you. We have like 40 questions here. I'm going to try to get through as many of them as I can. Another scenario is a scenario where somebody is on medication, they've already done OT, but they're still highly impulsive and in pretty like safety risk kinds of ways, like darting into the street, not looking for cars, things like that. Any advice there?
That's a really tough one. It's very scary. I think maybe I would wonder a little bit about why the medicine isn't working. Medicine typically targets impulsivity pretty well. And so I would maybe seek out more assessment, whether that's with a psychologist for testing or with the prescribing physician. When you see safety concerns like that, it's really important to just have a crisis plan and perhaps like more structured consequences or even rewards for following expectations. But because it's a safety concern, I would just want to really make sure that we're medicating correctly, and whether there isn't something else going on, like maybe like an anxiety, or maybe even just a misunderstanding of social boundaries, which you might see a little bit with autism and getting very overloaded. I would really want to clarify that.
Great, thank you. And then one other scenario is dinner time. How do you manage dinner time if your kid just has a very hard time sitting at the table with the family to eat dinner?
I would scaffold the time up. So meet them where they're at. Again, this is kind of where I started with acceptance, this idea of there's awareness and there's acceptance. So just realizing that your kids' limits, especially if their frustration tolerance is really low for dinner, that could be for a multitude of reasons. Just eating can be overstimulating, actually. That's the whole experience. But having to sit still and manage the body, having to interact, having to be around adults, all of that can be very maybe unnatural feeling for a kid, especially a younger kid. So I would maybe shorten the time and then build up. I would also, to improve engagement, maybe suggest either doing rosebud thorn, going around the table, everybody names a good thing from the day, a bad thing from the day, and what they're looking forward to, or doing a fun, engaging game. It could be maybe like people pass something under the table, or people answer funny questions, or whatever it is, just to associate dinner time with a positive interaction. Because otherwise, I mean, a kid is looking at it and be like, what? You want me to sit here while I wait for you guys to eat and talk about adult stuff? I mean, that sounds like the worst, really. So just sort of try to see it through your kids' eyes.
Great, thank you. There are a couple of questions here about getting an evaluation, or where do you go? So what do you suggest to your clients about where they start if they are thinking that their kid might have ADHD?
Reach out to Lisa Novak here. She's wonderful. So there's a few ways. I mean, honestly, it depends on whether or not you want to use insurance. Testing can cost thousands of dollars. And so some people are really motivated to use insurance. You can call your insurance for referral. You can reach out to your therapist. Usually therapists have people that they are more preferential towards. I love Rush Neurobehavioral Health. They're excellent with any neurodivergence. However, if you have a complicated situation, it actually might be better to go privately, because sometimes a private pay clinician will be able to dedicate more time, since they aren't bound by the requirements of insurance, and insurance will only cover up to a limit. And so providers are not motivated to go above and beyond because they're donating a lot of time. However, an out-of-pocket clinician will go above and beyond in terms of researching the records and doing in-school observations, things like that, where it really can be more helpful with the complicated cases. And I would encourage you guys to then reach out to Lisa for that. She's who I refer to all the time. So
thanks, Natalia. And I would say you can even start even before doing a neuropsych with your pediatrician and just express the concerns to your pediatrician. Oftentimes peds will, ask you a bunch of questions that can be helpful in understanding whether that does sound like ADHD or whether there are other things potentially at play. And sometimes they'll give out rating scales to you as the parents or caregivers and to the child's teachers to get a sense of whether they're really seeing enough symptoms in a variety of settings to even warrant either the diagnosis, which some pediatricians or psychiatrists will make, or to refer out then for a more comprehensive evaluation. I think, biased as I am, part of the benefit of a more comprehensive version is that if there are other issues at play, it gives a full picture. So there might be ADHD, but let's say the child's in 3rd grade or 5th grade, and we're thinking about that diagnosis. Has it impacted their learning over time? Are they behind now and need some additional support academically? Do they need some additional support socially? Is there anxiety as part of the profile? And so it really looks at a lot of areas that just doing kind of that focused initial exploration can't look at. And I know there was also a question about age for getting evaluated. Every provider, I think, feels really differently about that. Usually the younger, the better in terms of getting supports in place to really diagnose ADHD. Most providers don't make that diagnosis before 6, sometimes 5 years of age, but anything really school age and older, the sooner we can identify these things, the sooner we can take really good action to best help support your child so that there are fewer coexisting things that end up being at play there. Back to you guys with questions around sleep and ADHD, as well as the migraine comment you made. Any more information about migraines and ADHD, and or can sleeping disorders be a symptom of ADHD?
Absolutely. I can speak more about the sleeping and less about the migraines, but I mean, with ADHD, your mind is overactive and sensitive to things. And it's very common that I see people say things like, I can't shut my mind off at night, or I can't stop ruminating, or, thinking about different things. And so I think it's a pretty common occurrence that folks with ADHD might have sleep disorders as well.
Mm.
I would say that the most important factor in that is just maybe establishing a nightly routine. I talked to some of my clients about limiting screen time towards the end of the night, and maybe just doing something that signals to yourself that we're winding down for the night. But every person is different. Sometimes routines don't work for people, or of course medication might be helpful because that can really help quiet all those racing thoughts.
100%. I mean, there is a really high prevalence of sleep disorders among those with ADHD, and what the research cannot decipher is how much does the ADHD contribute to lack of sleep, and how much does the lack of sleep contribute to ADHD symptoms. And so what they're thinking is that there's something in the brain that actually predisposes people for both, but also there's clearly an interplay. And I will say anecdotally, I have struggled with sleep almost my entire life. I remember as a kid being up all night long, and now I have to have a weighted blanket, 3 blankets on top of me, socks on, a mask, earplugs, and 2 pillows. And I have cocooned myself on a really nice Sleep Number mattress, and I have finally found relief. And I was a long time melatonin user, but there is for sure that interaction that we're still trying to better understand. I think same with migraines. I think the thing with migraines too is that because it occurs more in females, you always kind of run the question of like how much do maybe differences in hormones and also any sort of internalizing of anxiety is presenting physically. And it's very difficult for research to at this time really like separate those.
Thank you. And we have a ton of questions still. This one feels like a really important one. How do you talk to children about them having ADHD? And is there language that you specifically use around that?
Yeah, I think when they're really young, I keep it pretty brief. I model a lot. So I disclose to all of my clients that I have ADHD, and especially with my kids, I will purposefully label when I've done something goofy or forgotten something or whatever that I attribute to ADHD. I will actually model for them that that's what it is and that it's okay. But with little kids, that's kind of the purpose, is modeling, but then also giving them a reason why they might then be getting all this support, because they often don't understand, or they might get annoyed that they have all these meetings. And so I might just say, hey, like, you and I both have something called ADHD. Have you heard that before? Yeah, that just means that our brain is like hooked up a little bit differently, and that we're more sensitive and that we're more creative and sometimes need a little bit of help with organizing stuff. I might only list like 3 symptoms that I know are specific to that kid and then not bring it up again. If they're older, I may talk about it a little bit differently because they can actually process it and they might make meaning out of it. They like a teenager or a preteen may want to understand how to identify with that, whether it's something that hinders them or whether it's something that is just a part of their experience. And so that might be a little bit of a different discussion.
And I'm actually just going to share a resource with everybody, which we can add to a resource list that we give you later. But Dr. Liz Angoff, Angoff, is a neuropsychologist who really specializes in talking to kids about their diagnoses. And her website has a ton of really helpful information that others might be able to use. A few last ones here. One is about accommodations and how they can be really helpful for kids with ADHD. But then is there also a concern that we're maybe over accommodating, and that if they're in environments later in life where they don't get these supports, that they're not going to know how to do these things on their own? And how do we find that balance?
Well, you're never trying to promote avoidance. So I think a lot of times people want to categorize either you're buckling up and like pushing through it, or you're avoiding the stressor. No, there's like a middle ground, right? And that really depends on your kid's frustration tolerance. It's all about how can they get through an experience successfully, even if it means with help, but based on the level of challenge that works for them. And if you're eliminating the challenge altogether, that's not great. That's promoting avoidance. So you want to make sure you're working with the school, that you're finding that middle ground, and maybe making some peace with, well, my kid has maybe a different expectation at this time because that's what their system can tolerate. And again, this is where development is on your side. If the correct supports are in place, what you actually will see is, you're promoting a lot of their independence, and you'll see them kind of grow through it.
Great. I know we didn't get to all the questions. I'm going to ask one very last one right now, which is that we know that ADHDers do get a lot of negative attention and redirection. How do we create more positivity for them in their lives, especially when they are doing things like forgetting their homework or not completing tasks?
I think honoring the spaces that they enjoy and do well in, and really prioritizing that, making it a big part of their life. So I have some kids where school is not their jam, but outside of school, they're awesome. They are participating in clubs, they're leaders, they're achieving with sports, and really sort of highlighting that as a priority in their life. And really kind of focusing on whether it's in the family or with their interests, what they have to offer, and really finding ways for them to show that, because it may not be in school, and that's okay.
Awesome. Thank you, guys. I know you had a hard stop at 1. I am seeing a bunch more questions that I'm still happy to answer. I know we have a lot of folks still on here, so I can stay for an additional 5 or 10 minutes if people have questions. And if you want to throw them back in the chat specifically, if you've already asked them and we haven't gotten to them, that would be great. But I do want to say thank you so much to both of you, Natalia and Laura. This was amazing and clearly, struck something with the community. So we so appreciate you being here and your expertise.
Absolutely.
Thank you for joining
Thanks
us.
for having us. It's been great.
Yes,
I'm always
thank
happy to
you.
come back and talk about this. We'll work on that list and get it to you by the end of the week.
Thank you,
All right,
guys.
everybody. Thanks for having me. Talk to you later.
Thank you.
Take care.
Bye.
Thank you.
All right. And then for those of you still on, I am going to continue through a couple of these other questions. One came in early that was asking about the levels of ADHD. Do we categorize it as mild, moderate, severe? The answer is technically yes. In our DSM, we do categorize it that way. I don't see it listed that frequently in reports that are written at our practice or elsewhere, but it is generally based on how many of the symptoms somebody is exhibiting, and more importantly, how much impact those symptoms are having on the person's life, be it, socially or academically, or for an adult in the work environment, whatever it may be. That's how we make that determination. There was another question that came in about tics. And I know it was mentioned that tic disorders do sometimes co-occur with ADHD, but how do we know if tics are a side effect of an ADHD med or if it is a tic condition that would have developed otherwise? And what I would say to that is none of us are MDs, and I would definitely defer to your prescribing physician for that. But we do, generally speaking, look for patterns. And so if the symptoms only showed up with a medication and then dissipated when they're not on the medication, that's often a sign that it is more of a side effect of the medication itself. There was a question about types of providers, psychologists versus psychiatrists versus counselors. I think the important thing to define there is less about whether a therapist is an LCPC or an LCSW or a clinical psychologist, and more so about the type of treatment that we're talking about. So the two buckets that we're really thinking here are therapy versus medication. Psychiatrists very rarely, but sometimes do therapy. Most of the time, psychiatrist's role is medication management. And so that's who you'd be looking for that. And all the other types of therapists and psychologists, we are not prescribers. We can't medicate. But for the therapy and the different kinds of tools that you can learn, coping and how to manage meltdowns and how to manage different kinds of behaviors, any type of therapist that's trained in working with ADHDers could be a really good fit for that. There was a question that came in about talking to sensitive kids about going to speak with somebody, but not having them feel like something is wrong with them. And actually, Dr. Liz Angoff, which I can share that website later, is really good at talking about these things as well. But essentially, the point is that if your kid is struggling, they generally have already developed a narrative that something's wrong with me. And by offering them, hey, it seems like you're struggling with X, whatever that may be, let's figure out a way to best help you with that. They are usually quite empowered by that feeling as opposed to knocked down by it. And being able to be problem solvers together and use the child's language. So even if you're seeing things that you want to be, fixed or treated or worked on, it might not be the very same thing that your child is seeing, but it can still be really helpful to use whatever that your child is noticing is the problem to then give them a reason to go find some answers for that problem. And so when we speak pretty openly with our kids and we also highlight their really wonderful strengths and say, look, we want your strengths to shine, but we see that you're being dragged down by this thing that's feeling really hard for you, and we just don't want it to feel so hard anymore, that can be pretty empowering. All right, we're almost done here, and I know we still won't be able to get to all of them, but hang out for another minute or two here. One is the night owl ADHD son. I know we talked about sleep a lot, but that is a very common problem with ADHDers, is that we see difficulty falling asleep at night and then difficulty waking up in the morning. Sometimes medication can really help with that, but outside of that, I would just say, yes, that's a common presentation that we see with ADHD. And I think that is how can I help regulate emotions in school? That's a really good question, and it depends a little bit on what's causing some of that dysregulation in the school setting. It's hard to give a one-off answer for that, but I would talk to whatever provider you're working with, be it your pediatrician or if your child has a therapist, and figure out what tools are working outside of school and try to bring them into the school environment as much as you can. So things like giving a break, using a little sensory bucket of tools that you know are calming for that child, figuring out what the antecedent is to those dysregulated moments and trying to kind of catch the child before those things happen or set up additional supports around those events so that we see less of that dysregulation happen later. But I think that's a really, really good question that talking to whomever is on your team can be really helpful for. I'm sorry that we didn't get a chance to get to all of them. I do have to sign off for now, but we really do appreciate it. And one thing I suggest you do is actually reach out to Catch. You can find us through our website. If you have more topics that are related to this that you want to hear more about, we'd love to set up additional programming to help get those questions answered. Thank you guys for being with us today. We really appreciate it. And we do have one more Lunch and Learn coming up to round out the end of our spring. It is coming up next month on May 14th, and it is with Harlan Cohen, and he will be talking about 5 simple rules for high school and college parents. So be sure to tune in and join